Didn't mean to record. We are live. We are live. Good evening, everyone, and welcome to another episode of Back to Basics. I believe this is episode 23. We've done a lot of episodes. I thank you guys all for joining us this evening. Let me just sort of like get in the zone. I'm gonna put the blinds down because it's distracting us a little bit. That's better. And let's get, it's the other one. I think it's gonna rain. Perfect. So let us get cozy and comfortable. My name is Dr. Viviana Samoa. I am a gastroenterologist and a functional medicine provider in Katy, Texas. We have been, enjoying each other's company as a family on natural gut relief for several months now, almost half a year. This is a wonderful, safe, and informative space where we discuss everything related to natural gut relief. So as a gastroenterologist and a functional medicine provider, I love discussing different topics and getting ideas from you guys and suggestions. And today, I thought it was really important to bring a topic that I see commonly in my practice and get a lot of questions about the gallbladder, which if you have watched a previous gut over video that I did when I was doing the Gut Over It series, I talked about the gut bladder being the biggest mimicker because it has fooled me in many times where patients come in with very weird symptoms and I do like an EGD and a colonoscopy and many things. And, somehow at the end of the day, we find out it was the gallbladder. So I want to make sure that everyone can hear me. I think that this platform I'm using, StreamYard, they've modified a little bit. So if y'all can hear me, please put in a like. Please share some love. Leave a comment, leave a question so that I can see what's going on. Okay. And it's great to see so many of you guys on tonight. We have a special guest. Dr. Agarwal with AG Radiology. We'll be bringing him on in a little bit, but I wanted to give you guys some background about gallstones and gallbladder disease before talking about imaging related to gallbladder disease. Okay, so Nerdia Samoa, I did my research and I learned quite a lot of things. Yes, thank you. Yes, it is. I'm glad to see you guys. It is pouring in Cinco. And today I had to leave my car at home because it was getting cleaned. I haven't cleaned it in a long time. So I had to Uber. So I will be Ubering home and I'm not looking forward to it. So yes, it is pouring. Hopefully it's done by the time we're done. So, I just wanted to get you guys some stats because every time people have pain, they feel like I'm the only one going through this. Guess what, guys? 20 million people in the US have gallbladder, just gallstones. Let's just say gallstones. There are 300,000 cholecystectomies performed every year in the United States of America. It is the fourth most common cause of emergency room admissions, the fourth. So we're seeing a combination of sludge, sand, large stones up to 3 centimeters in the gallbladder. There are several different types of stones, and we'll talk about, we won't be too nerdy, but I think it's important to know. Most of the stones that we see in the US, 75 to 80% of these stones are cholesterol stones. It comes from fat, right? About 15% are what we call pigment stones. You have black pigment and brown pigment, and this comes from hemolysis, releasing a lot of bilirubin in the system. We see this in people who have sickle cell trait, any kind of hemolytic disorder like thalassemia. And then sometimes we'll see the brown stones from infections of the gallbladder, right? Flukes like Ascaris Clostridium, E. coli can all infect the gallbladder. So sometimes we don't think about this. We think, oh, it's all just fat. But remember, 15% of people with gallstones could either be from a parasite, from a bacteria causing that cholecystitis. So because I want Dr. Agarwal to have some time to really talk about, testing and stuff, I want to jump into what these stones are made from. We talked about the cholesterol stones. So really what it is, it's bile, which is made in the liver, that is supersaturated with cholesterol, right? And then it crystallizes and forms a little nidus stone. And then the stone that crystal just keeps packing on top of that. Then you've got the sandy, what we call sludge, which is also bile and cholesterol, but it doesn't form that nidus, so that stone doesn't form yet. It's more like a sandy, sludgy substance in the gallbladder, right? Okay, great. Now, so what I learned is that a whole bunch of people can have gallstones and never have symptoms, right? Never have symptoms. In actual fact, in people who have gallstones, like 60 to 70% of gallstones, 60 to 70%, no symptoms. So that means the majority of people with stones have no symptoms. So when you have someone with, you do an ultrasound, you see gallstones, you really, the provider has to be sure that the symptoms kind of match what, fit the gallstone, disease, gallstone picture, right? Is this a presentation of gallstone disease, right? Or is it just an incidental finding of gallstones? And so the problem then becomes, you send this patient off for surgery just because they happen to have gallstones, and they come out of surgery without a gallbladder, but they didn't get better. They have the same symptoms they went in with. So let's talk about symptoms, right? Gallstone disease. How can people present? As I said, I really do believe it's the biggest mimicker because I've missed it so many times, but the classic symptoms falls really into three categories, right? Everyone always think of that acute attack, what we call the biliary colic, right? That is when a stone is trying to sort of exit the ducts and it's getting stuck. It's causing like a little bit of an obstruction that hurts, right? That is pain that you will experience probably like an hour or so after a fatty meal. It can last for an hour to 5 hours, right? It's very painful. And then it subsides because that stone that was sort of getting trapped in there falls back into the gallbladder sac, and then you feel better until the next attack, until you have that next fatty meal and it happens. So that's biliary colic. And I think in our practice, when we see patients, for the most part, it's biliary colic, right? Then you've got acute cholecystitis. That is now inflammation in the gallbladder, right? A lot of people will present with nausea, with vomiting. The pain lasts for a long time. The pain is in the right upper quadrant. Let me not forget to say that, because sometimes I see people coming in with gallstones and like, oh, it hurts here. I'm like, no, that's not the gallbladder. That's not the gallbladder, please. The gallbladder, so if your heart is here, right, that's left side, the gallbladder pain is on the right side under that rib cage. It cradles right under the liver, right? So some people are like, oh, my gallbladder hurts. No. We all, the right upper quadrant. Okay, everyone on this group, we got to get it right upper quadrant. So we talked about biliary colic, which is the episodic one, right? The stone now falls back. We talked about acute cholecystitis. Now that is the one everyone has heard about. My cousin went to the ER. She was in severe pain. She was like, her right upper quadrant was hurting. She had just had a Whataburger and she was nauseous. She was puking. She had to go to the ER. They gave her IV drip. She had fever. The surgeon walked in, boom, 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 took out the gallbladder. She was better the next day. Classic acute cholecystitis, right? I don't know if I see that very often in clinic. I think the pain is so bad that I either send them straight to the ER or, people go straight to the ER. And then you've got the third category, which is called chronic cholecystitis. So this is kind of the gallbladders being diseased for a while. There's scarring. It's inflamed, but there's scarring. It's been a chronic inflammation that we know leads to scarring. There's scarring around it. It's like a contracted, all shriveled up gallbladder. And it doesn't contract very well. It doesn't move very well. So every time you eat a fatty meal, every time you have that Whataburger or that foie gras or whatever, and it's trying to release bile, it's almost like a difficult thing trying to release bile. It's painful. It's painful, but it's chronically painful. And gallbladder pain can start in the right upper quadrant, but because of the nerves endings, gallbladder pain can radiate to the right shoulder. It can radiate to the back. People are like, oh, my back hurts. I have back pain. I have back pain 1 hour after I eat. It's your gallbladder, even without the right upper quadrant pain. So that's really important to kind of think about that back pain that's really on that lateral side. It doesn't necessarily radiate. It can just be like this aching in the back, right? So that's really important sign of gallbladder issues, right? So we talked about the different presentations. That's how it can present. And very often, we start talking about, when you see a doctor like myself, a gastroenterologist, and, we think that it's gallbladder disease, a conventional gastroenterologist, the first thing we'll say is, well, let's get some testing done. I'm going to let Dr. Agarwal get on that testing. Well, we'll say, hey, if you don't get the testing, so many bad things could happen. It could really be badness. The acute cholecystitis, which is an inflammation and an acute infection of the gallbladder, could cause sepsis, which is inflammation throughout the body, and you need urgent surgery, and it's just bad. Or the little stones that come out through the cystic duct, which is the duct of the gallbladder, can get stuck permanently and cause a backup of pressure into the liver. So sometimes when we do blood work, a lot of times when the obstruction is there, guys, we'll notice that the liver enzymes jump. They jump up. That can be a cause, right? Or we'll see obstruction, a backup downhill, which is right where it connects to the pancreas, and you develop pancreatitis, which is this excruciating pain of the pancreas. I mean, you don't want that, right? Or the ducts themselves can get infected and you get cholangitis, and that gives you, the sepsis. I mean, we can, all the way to, you can have the stones get stuck, and then you get pancreatitis, and then you need a procedure to go remove the stones, and then you can get sepsis, and then you can get perforation and gangrene, and then you can die. I mean, that's how bad we say it, right? Because in a small percentage of patients with acute cholecystitis who develop cholangitis, which is inflammation in the bile duct, yes, this can happen. But this is a category, right? So I mean, it's important to put everything in perspective. And guys, please remember, don't go out there saying Dr. Vivian, Dr. Somewhere, Dr. V is telling us it's okay to have gallstones. This is all educational information that I'm presenting here today. For everything, you're going to have to talk to your primary care provider, whoever's taking care of you, get the necessary testing and whatever is needed. But sometimes I do think that we kind of blow things out of proportion. Patients get scared and do get their gallbladders sooner, earlier than they need to. But sometimes it is important to get it out. And that's what we want to talk about. When do you make that decision? If you look at the studies, there's a small percentage of patients who will develop gallbladder cancer from having gallstones for a long time. And I think this kind of goes back to that fundamental of probably what they have is the chronic cholecystitis, chronic inflammation, right? And we know that anything that results from chronic inflammation can increase your risk of cancer. So you kind of have to think about, okay, if you keep having right upper quadrant pain and you really do suspect it's gallbladders, gallstones, and you have done whatever flush, and we'll talk about flushes, we'll get onto that topic. You have done whatever kind of treatment, and every 3-6 months, you still continue to have that pain and you refuse to get your gallbladder out. You're having chronic inflammation in your body, which can make you tired, which can lead to inflammation elsewhere, which can lead to digestive issues like SIBO, and this chronic inflammation over years and decades may lead to gallbladder cancer. So you have to think that it's not that benign. You don't want to lose that gallbladder, but have you really weighed the risks and the benefits of keeping it in for a long time? So we'll talk about that in a little bit more detail once I get Dr. Agarwal on board. But something that I missed, and I want to emphasize this because it's important, guys, is, why do some people get stones? Why do some people have stones and have no symptoms, right? I mean, I remember as a med student, and I studied at the University of Geneva. I don't know, somehow they focused a lot on anatomy. And I would get all these, we had a lot of old, our cadavers were like 90 years old, 100 years old, right? Because I think people live really healthy in some parts of Europe, and they live really long lives. And, whenever it would come to gallbladder dissection, we would find people like 102 years old. And we would dissect that right upper quadrant fossa and find a gallbladder with like tons of stones, like tons. And you always wondered, wow, they never had an attack. They just accumulated these stones over years and really never had pain and never had an issue, right? Which is where I think the importance of diet comes in. You can have the stone, but what triggers that inflammation? What triggers those stones to move? What causes symptoms? Maybe you're not flushing. You're not flushing well. Maybe the diet is off. But we saw a ton of cadavers that we dissected that had tons of stones, but these people didn't die of gallstones or sepsis. They died a natural death or cardiac disease or something else, right? But we know that there's some people who are high risk for having gallbladder disease and gallstones, right? And in med school, they teach us about the 5 Fs. And, in hindsight now that I'm thinking of it, and I'm in my 40s, I find this whole thing really offensive. But the 5F was a mnemonic we had to remember for, when you're answering questions, who is high risk for gallbladder disease? Fat, female, fair, so Caucasian, 40, and fertile. Those were the 5F. You knew that category, this group of people were going to be high risk for gallstones and gallbladder disease. That was the mnemonic. But family history plays a role. So when I see patients, I always ask, hey, did your mom have gallbladder disease? Did they have sister? Yes, very likely. Rapid weight loss. If you lose weight suddenly, so we often see people who have had bariatric surgery lose like 100 pounds, gallstones. So in the past, the surgeons used to actually remove the gallbladder at the time of the bariatric surgery to prevent gallstone and then having to go back in for another surgery, right? Pregnancy, because of the high estrogen. And along with that, everything is sluggish, right? And so the gallbladder doesn't squeeze well. People who take oral contraception, people who are on hormone replacement therapy, women on hormone replacement therapy, Hispanic population, very high risk. I think that could be genetic and maybe diet related. People with low stomach acid, the naturopath doctors and I think functional medicine providers really believe that could be a component of food sensitivity. And then of course, infections. We talked about parasites, flukes, C. diff and other types of infections that can increase risk of gallstone disease and gallbladder infection. So we've learned a lot, guys. I hope you guys have questions. I'm not seeing a lot of questions come through, but I will answer them in the comments. But I want to leave enough time for Dr. Agarwal to talk about different modalities for testing. So as a gastroenterologist, I work with a lot of surgeons and I work with a lot of radiologists. And it is amazing to have an awesome, highly intelligent, super expert in what he does, nerdier than nerdy. He's nerdier than me. He's nerdier than me. Dr. Agarwal, thank you for joining us on Back to Basics. Dr. Agarwal is the radiologist, the main radiologist at AG Radiology right here in Katy, not too far from us, Dr. Agarwal. I want you to tell us a little bit about yourself, a little bit about your center, the different types of tests you offer, and then we'll dig right into this gallbladder story.
Thank you, Vivian, and thank you to all the listeners. We are located at 601 Park Grove Drive, which is very close to I-10 and Mason.
Mhm.
And I've been here in this center for 10 years. Before that, I was in private practice for 10 plus years. And before that, I was in the training throughout, but with the practice background from LSU Shreveport. And I'm also a radiologist from India, trained in India too. So I've seen the complex of disease from the Western world as well as from the Eastern side.
Mhm.
So I've been in practice in total for about 30 years as a radiology.
Okay.
And here at our center in KT, we provide facilities for X-ray, ultrasound, CT, MRI, and the other modalities that we have, but not related to at the GI topic, but we still do
Mhm.
mammograms and bone density. Sometimes
Mhm.
they are handy and useful too
Yeah.
for the women population.
Yeah. That is fantastic. Can you tell us your opening hours? Because sometimes patients always ask, when is it the place going to be open? When can
Okay.
I do my test?
Yes. So we open Monday to Friday and
Okay.
Monday to Thursday from 8 to 5 every day. And on Fridays, we are doing right now 8 to 4. But my office manager and everyone are saying that either we extend the time or we are going to reduce the time, depending on the manpower and the COVID situation.
Yes, yes, yes. And I
So
know you
we are
guys,
all facing through that. Saturday,
yeah,
Sunday, we are not open yet. But in case if there's a need for the community, we will still be more than happy to open up half
yeah,
days. Yeah.
yeah. It was really great. When we got that first wave of COVID, a lot of our patients could not get testing at the hospital. They had to get, everything was shut down. Elective, even semi urgent stuff could not get done. And it was really great being able to refer patients to you, Dr. Agarwal, to get their testing done, and so we could get diagnosis and start treatment and move on. So I'm really grateful for you for still seeing patients and following all the COVID guidelines and everything. Yeah.
Yes. Thank you very much, right. And the reason we actually also kept ourselves open during this time, because we did notice that most of the people did not prefer to go to the hospitals
Yeah.
because that was high risk at that time.
Yeah.
And the difference that we made here is by following all the protocols, but operating as like an operating room or
Hmm.
an endoscopy room where we were taking one patient in and one patient out
Got it.
and doing all the precautions we could, right? Yes.
Got it. Got it. Got it. That's awesome. Well, let's jump right into this gallbladder topic. And we see someone with abdominal right upper quadrant pain, and our suspicion is gallstone disease or gallbladder disease. What are the tests that what are the best tests to recommend?
So the first and the best test that we always should be looking for is an ultrasound.
Hmm.
And the reason is because number one, it's there's no radiation.
Hmm.
Number two, it's very easily accessible. Number three, there are no insurance issues in terms of certification, pre-certifications, or
Okay.
approval.
Okay.
And number four, it's very, very sensitive and specific to gallbladder.
I see. I
The
see.
only requirement for an ultrasound is 4 to 6 hours of fasting.
Okay. Excellent. And an ultrasound does not hurt. It is not painful. It's like an ultrasound. How long does it take to do an ultrasound from start to finish by the technician?
Yes. So depending on the experience of the technician,
Mhm.
as well as the experience of the overall facility, uh, overall it takes about 20 minutes for an
Okay.
average ultrasound for a complete abdomen ultrasound. But if you have to look at only the right upper quadrant, it's between 15 minutes. And this is not because we are rushing in or anything, but we want to do a good test, complete test. And to an average, sometimes it can extend up to 30 minutes, depending on what all findings we get. Because the more findings a patient have either in liver or the other organs, we have to document all those things, and that extends the time, right?
Okay. 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 So when you're looking at the gallbladder, right? When you do an ultrasound and you're looking at the gallbladder, what specifically do you look at? What are you looking for?
Yes. So the first thing we look for is the gallbladder well distended after the and if the patient says that they have been fasting surely for 6 hours, did not
Mhm.
eat,
Mhm.
no burgers, no breakfast, for
Mhm.
sure.
Mhm.
That means, and if the gallbladder is well distended like a sac, like a balloon filled with water or bile, that's the first thing we are looking for. But if it is not, then there is a problem. We already noticed that the gallbladder is small despite fasting. That indicates there is a problem with the gallbladder when it's contracted. The
Mhm.
next thing we are looking for is what is inside of the gallbladder. What is it filled with? Are they like round, little round marbles? And if they are, what size they are? We'll call them stones.
Okay.
Number third, we are looking for is the wall, the gallbladder wall, how thick it is. Normal thickness is up to 2 to 3 millimeters. Anything above that, we know that there is a problem going on in the gallbladder itself.
Okay.
Yes. Number four, we are looking for the fluid. If there is any fluid surrounding the wall of the gallbladder. But with additional information and additional things we are looking for is the bile duct. As you mentioned, the passage of bile from liver to gallbladder is through cystic duct. We cannot see the cystic duct, but we can see the bile duct coming
Okay.
from, whether it is big, small, dilated, or what is happening with it.
Excellent. Excellent. So, can you guys tell what type of stones are in the gallbladder sac from just an ultrasound?
So type of gallstones, I think so you're referring to whether it is pigment,
Or
cholesterol,
mhm,
or the mixed type, right?
right.
Luckily for us as radiologists and for gastroenterologists, it's 70% are mixed stones for sure. So
Mhm.
70-75%. And the only way we can know for sure what type it is or what we are looking at is if the gallstone starts shadowing. So once we do the ultrasound, we know they are round marbles. And if I start seeing shadowing, that means they are definitely bile type of a stone, more of uh, and less of a pigment type of stone.
Got it.
But if I
Got it.
see stones that are not shadowing and they're small, then I know I may be looking at, and if they're soft, then I may be looking at more of a cholesterol type of stones.
Mhm.
It's not 100%, but it's just a guidance for us that
Got
we
it.
can still, yeah, that we can still suspect, right? But most of the time they're a combination of both, as you said, right? Yeah.
Excellent. Excellent. Does the size and the number of stones, have you seen from your experience, does it matter? Small stones versus large stones, 20 stones versus four. What are your thoughts there?
Yes. So that's a very good question. And as you said, when you were dissecting the cadavers, you saw a gallbladder full of stones.
Yes.
Hopefully they didn't die of gallstones. But again, as also you said, there are stones. People have stones, but they're asymptomatic.
Asymptomatic. Yeah.
Yeah. So my theory that I have researched and understood over so much time is if there is a stone which is 3 centimeter size, it is sitting in the gallbladder, it will sit for the whole rest of their life. And if that's the only stone, they will have no problems, no symptoms. So that's why the size is
Oh,
important. Because a 3 centimeter size stone is sitting is going to sit in the sac. It will never try to pass through the
okay.
cystic duct.
Okay.
So it's just sitting
It's
right
just
there.
sitting there. Okay.
Yes. Now
So,
the stones that are matter is a size coming down to less than a centimeter,
yes.
and small stones definitely are multiple small stones
Traveling.
will
Hmm.
try to pass through the cystic duct
Got it.
every time the patient eats and will have symptoms. So
Wow.
that's why
That
the
is
size
interesting.
of the stone is very important.
Right. 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 Right.
Now, number of stones, as
Mm-hmm.
you, this was the second part of the question, said that uh, whether it's one stone or two stones, it will matter out if there are less than 4 or 5 stones, and if they're less than 4 and 5 millimeters.
Mm-hmm.
With the flush therapy, sometimes people will be able to pass those,
Has those.
and maybe I'm not sure,
Yeah.
but they will. But we, and if they come back again, we may not see them.
Got it. Got it.
But if there anything more than 5 millimeters is going to definitely be present again.
I see. I see. So, oh, I see. That's really interesting. Anything more than 5 millimeters, you're going to see that. You're not. It's not going to flush away, in your opinion.
It will be very hard.
Very hard for that to flush away. That's really great information. How big is 3 centimeters? I know, Doc, we often talk in centimeters. What is that in inches? I'm gonna have to take
So
my
no, so the 3 centimeter is a very simple, like, golf ball size. or
Golf
less than
ball
a,
size.
yeah, less
That's
than a
right. Golf balls. That's big. Yeah, that's
yes,
pretty big. That's a pretty big.
that's right. Yeah.
Okay. We have a great question from from Gisela. I hope I'm saying your name right, but anyway, Longoris. And this was my question for you. If someone has had their gallbladder removed and they're having right upper quadrant pain, what kind of testing do we do? Is an ultrasound still helpful? What kind of test do we offer?
Yes. So ultrasound definitely is the first line of test, and it's
Okay.
very helpful. The reason is because now we are looking at, after we get that history that the gallbladder is out, we are looking at the liver, we are looking at the common bile duct
Okay.
and the ducts within the liver plus the pancreas. Also, we are also looking at, during this time, we do look at the right kidney too,
Mm-hmm.
just to make sure that it's not, if that's the reason for the pain or not, right?
Got it.
So once we know that the common bile duct, we can visualize it, and it is either five, big, small, or non-dilated or dilated, or there is a potential that a stone could have lodged in or formed into the common bile duct. So we can pick up those findings with ultrasound.
Yeah. Because even though your gallbladder has been removed, your liver still makes bile. And this bile has to drain through the piping, right? The connections, and things can still crystallize and stones can still form there. And that's what we call choledocolithiasis, when the stones are actually in the piping, right? Stuck in between. So yes, it's still really important to do that. So tell us a little bit about the HIDA scan. When do we order that HIDA scan? How reliable is the HIDA scan? What are your thoughts on that, Dr. Agarwal?
Yeah, so HIDA scan is again the second or the third line of test.
Mm-hmm.
I would say second in situations. The first is always ultrasound. The reason is because you have to know whether there are stones or not,
Mm-hmm.
because that will determine how the HIDA scan is ordered. As soon as one doctor sees a report, gallstones present, yes, but I'm not sure whether it's gallbladder disease or not. So then HIDA scan is a test which is a functional test of the gallbladder, and it's done by a nuclear medicine camera. It's a nuclear medicine test where we have to still inject a little bit of dye in the patient's vein, and
Mm-hmm.
it goes through the system, and then it concentrates in the liver.
Mm-hmm.
After that, it starts excreting, and we start taking pictures under a camera. So that's HIDA scan. And what it is going to tell us is whether that bile is able to come inside the gallbladder or not. If it comes inside, whether it's able to leave outside the gallbladder or not. So the difference would be, if there are no stones in the gallbladder ultrasound, then the HIDA scan is ordered with CCK, which is the second
Yeah.
part of the test. Uh, if there are stones in the gallbladder, the HIDA scan is usually ordered without the CCK.
Okay. So CCK is a kind of hormone peptide that causes the gallbladder to contract, right?
Yes.
Right. So that we want to kind of see how well the gallbladder fills and empties. So that's why we give that. I know in some places they give ice cream because that will also is high fat. That will also stimulate the gallbladder to contract. So that's good. But something important that you said is, if the patient has stones seen on ultrasound, you do the HIDA without CCK. If the
Yes.
patient does not have stones, you do the HIDA with CCK,
CCK.
right? And
Yes.
this is because why that distinction?
Yes. So the reason is because, just imagine somebody who's having the ice cream or the fatty meal, which
Mm-hmm.
is equivalent to the CCK.
Mm-hmm.
And if you have small stones,
Yeah.
small size stones within the
Mm-hmm.
gallbladder,
Mm-hmm.
as soon as we give this medicine, it was going to contract the gallbladder, and it's going to push the bile as well as few stones through that small cystic duct into the common bile duct, and the patient could experience the pain and the discomfort that they were already experiencing, and
Right.
could make it worse.
Could make it worse. Could make it worse. Okay, so that's really important. So I see some patients and they say, "Oh, I had a CT scan." But before I say that, I want to answer a question for one of my patients, Judy, because she's not on right now, but she has a question. She does not have stone issue, right? In what other scenario would you do a HIDA scan? Like if you're not looking necessarily for stones. per se. Just looking kind of like the flow of bile. That
Yes.
helps, right? For the flow of
Yes.
bile. Mm-hmm.
Right. So the next scenario is HIDA scan with CCK
Mm-hmm.
when there are no stones in the gallbladder, but still we are suspecting that the gallbladder is the likely cause of the patient's symptoms. So as soon as we do the HIDA scan with CCK, we see the functionality of the gallbladder and the flow, and see
Okay.
how that gallbladder is functional to empty.
Functional. Got it.
It's
Got
called the ejection fraction. You will see a number. So there are two scenarios here. The gallbladder could be functioning faster,
it. Uh-huh.
and it could be, yes,
That can be
hyperactive
problematic.
gallbladder, and the
Hyperdynamic
patient can still
gallbladder.
experience the symptoms, or
Yes.
it could be a slow functioning gallbladder
Yes.
where the gallbladder keeps on distending, having the bile, and then still there's a problem.
Yeah.
So once we know that number, the magic number, we can still help the gastroenterologist decide, yes, this most likely. And it's very helpful in scenarios called, as you mentioned, about chronic cholecystitis, where the
Mm-hmm.
gallbladder is contracted, where there is a
Mm-hmm.
problem. It does look, but ultrasound is not very sure what is happening.
Right.
And we do the HIDA scan, it will help.
Right. Excellent. I mean, there's so much we could discuss about the gallbladder. Let me add one more thing in terms of testing. So I sometimes will see patients and they're like, well, I had a CAT scan. My CAT scan was fine. My gallbladder was okay. Right? What do you say about that? Is the CAT scan reliable enough to assess the gallbladder? CAT scan done in the emergency room?
So the only time it's reliable if the stones are radio opaque.
Mm-hmm.
So that's when you can see the stones on the CAT scan, you know there's gallstones.
Mm-hmm.
But if the stones are not radio opaque, that means you cannot see it on an X-ray or a CAT scan.
Mm-hmm.
We will still miss, and we'll say there's no gallbladder stones, but as soon as we do ultrasound, we'll start seeing the stones.
You see the stone.
So when the report says no calcified gallstone, that means there could be some stones still which are not seen by CAT scan.
Absolutely. So I have a question from one of our members, and she says she has seen a lot of younger girls needing gallbladder out, often after childbirth. Is it because of the weight loss or other factors, right? I think a lot of it is, well, let's just say generally young girls are not always eating healthy, right? So there's a lot of fat intake, carbohydrate intake. Another thing is the hormonal shift that we mentioned, the high estrogen during pregnancy. And so they form the stones because the gallbladder is also very sluggish. It doesn't empty well during pregnancy. So more stones are being formed during that time. So gallstone disease during pregnancy and right after pregnancy, very common because of these different issues. And then we also know if you live in Texas, one of my youngest patients, 16, Hispanic, she just had a child. So we know it's high in the Hispanic population, female, fertile, and she had gallstones and needed her gallbladder out very quickly. So yes, indeed, we are seeing more and more of this, right? More and more of this. So you mentioned the word flush. So you must be seeing quite a few patients who are coming in after they've done their gallbladder flush. And again, as I said, I went undercover at a liver and gallbladder flush Facebook group. I've been undercover there for a couple weeks already, just to I like to hear what people are saying, what kind of flushes they're doing. And, overall, I think it's always, you can't judge something that you don't know a lot about. So I think a lot of conventional doctors, don't agree with the flush. But there are a lot of very, highly educated, intelligent people on these forums sharing ideas, sharing their experience, right? So a flush is a way to sort of like flush out the entire bile duct system and gallbladder, right? Using natural remedies. We'll see people doing coffee enemas, colonics, using magnesium, using apple cider vinegar, grapefruit juice, olive oil. I mean, there are multiple different protocols, right, that I actually learned from this forum. As a gastroenterologist, but more so as a functional medicine provider, I have flush in my office. I actually have a flush kit from a company that I researched called Global Healing Center. I researched their flush kit. I looked at the safety. I looked at the contents, because sometimes I do have patients who don't want to have a gallbladder surgery. They want to try a flush. I want to give them something safe. And, after speaking to a lot of naturopaths and homeopaths and people also, our providers, our healers from the East, they do flushes and they don't see any major issues. There's always this thought that, if you flush, maybe the stone is going to get stuck, whatever. I don't know that we see too much of that. Just given the number of people on this forum that are flushing, yes, they can experience pain. I definitely think they do experience the symptoms, right? But the thought process is that these stones are flushing out. Now, very interesting. I actually spoke to a naturopathic doctor she's like the gallbladder naturopathic queen. That's all she does. And this comes from a naturopathic doctor with over 30 years of experience. And she said, Viv, what they calling stones, because people are like, oh, the stones came out of my gallbladder. They came out. She goes, I've been doing this for years. It is totally fine to flush. Do it safely. But what they are calling stones are not stones. They are sort of precipitates of the materials they ingested that kind of, by chemical reaction, forms these little like stone appearing things. But she actually went as far as collecting them from a patient, analyzing the chemical components, and they were not mixed stones or cholesterol stones or whatever. So some people swear that after a flush, they do an ultrasound and the gallstones have vanished like magic. From what I understand, what Dr. Agarwal said, when the stones are larger than 5 millimeters, they usually don't budge. Is that correct?
Yes.
Yes. They don't budge. They don't budge. So I think the flush is great for just sort of cleansing out your system, right? Because you have to do a fast for like 10 hours. There's a whole protocol, right? It's a great way for detoxing and cleansing out your system. And I think it calms things down, because you have to imagine that when there are lots of stones and this nida sitting there, probably a breeding ground for bacteria as well, right? That's kind of how cholecystitis happens. So maybe that flush and detoxing and clearing everything from liver, gallbladder, generally, from what I've seen in my few, maybe 20 patients who've done flushes and had good results, but the stones have never gone away. I have always done an ultrasound. I have never seen them disappear, but from what they feel better, and they can feel better for maybe 3 to 6 months. And when they notice the symptoms coming again, they flush again, right? All of this to avoid having gallbladder surgery. Because, there are many pros and cons to gallbladder surgery, but if you're having pain quite frequently and you're having to go through this whole process of flushing, I don't know if it's truly worth it or not, but that is what some people do. I've also been asked the question as to whether we can just remove the stones and leave the gallbladder in place. Patients often have this question, can you just take the stones out? No, you cannot take the stones out. You can remove a stone from a bile duct that is stuck, right, by doing a procedure called ERCP. But going in and actually removing the stones, we can't. And consider that the sac that these stones are sitting in is probably diseased itself. So if you leave the sac there and it doesn't squeeze well, it's very possible that the stones will form again. There are certain medications that we give, like ursodiol, to prevent further stone formation. We may use it in somebody who has, who's maybe not a good candidate for surgery for whatever reason, cardiac or whatever reason. And so ursodiol can reduce prevent future stone formation, but also does not get rid of all the other stones, like the existing stones there, right? So there's a lot of information about flushes. If you guys want a little bit of information, I can share the flush that I've researched. There's talk about diet. When we posted something about diet to avoid future stones, low fat and really kind of low protein. We want a diet that's rich in vegetables, and fruits, right? So really keeping it low fat is important. The naturopaths also believe, I think functional medicine, we generally do believe that there could be a component of food sensitivity. So doing something like an elimination diet to see if that affects your symptoms is often very helpful. Fiber, fiber, fiber. So that's why we talk about the fruits and vegetables, right? To help the body move, to increase prebiotics in the system, which may help reduce flares. So those are all natural and important things that we can do in terms of helping reduce symptom formation, right? But not eradicating or eliminating the stones altogether without surgery, right? There are lots of homeopathic remedies. Shankapedra is a common one that is used all around the world for gallstone symptom prevention, especially biliary colic. Dandelion, artichoke, these are some natural remedies that are used. There's a lot of great homeopathic remedies also for gallstone, just kind of the flow of bile from liver and bile ducts. And I'm happy to recommend more of these if you guys ask. I will definitely leave some information in the comments box. I want to make sure I haven't forgotten anything in terms of naturopathic remedies. Peppermint oil capsules have been shown to help. That works really well. Shankapiedra, I think, is what I saw people on the Gallbladder Flush Facebook group using for the most part. So it's a combination of different tannins, flavonoids that we know helps really well in kidney stones. And there's also benefit in gallstones. And I can give you guys the dosage. Castor oil packs, because naturally cause some, contraction, right? It stimulates the gallbladder. So castor oil has been shown to work as well. And so I think generally we've kind of circled around all of this. Now, after surgery, doc, right? What kind of complications have you seen? Like if people get the gallbladder removed surgically, for the most part, I think gallbladder surgery is usually a seamless procedure, but with every surgery, there can be complications. What have you seen?
So as you mentioned, number one, we can always say that gallbladder surgery has come so far that it's the most safest surgery.
Mm-hmm.
Anybody goes underneath, it's because of the two different types. First, it was an open surgery. Now it's laparoscopic surgery.
Correct.
It's still the safest, right?
Mm-hmm.
There are only 2 or 3 simple procedures that can occur after surgery. Suppose if one of the clips slip, where they block the passage of the bile duct connection from the gallbladder to the common bile duct. If that slips, one of the complication is called as biliary leak or a bile leak. So if that occurs, that can be picked up very easily, because if it goes in the abdomen area, it starts to irritating and the patient can have biliary peritonitis. Mm-hmm. And the test they usually order is definitely the hyda scan in that scenario to see where that bile goes from the hyda scan. Mm-hmm. Yes, that's one of the things. And then sometimes there could be a fluid collection in the gallbladder fossa, which we call it like a little seroma. Mm-hmm. But normally the body absorbs that by itself.
Over time,
right? Yeah. So that usually get absorbed, right? Okay. The other thing that I have seen, and it comes not very often, is again a stone formation after a few months or a year in the common bile duct, the tube that connects, right? Mm-hmm. But for that, the exam is to start with, and a non-invasive exam would be MRI, which we call it the MRCP, to know how that common bile duct is and what is happening inside the common bile duct, right? Yeah.
Got it. That's great information. So the ultrasound, the hyda scan are still very helpful tests to look at post gallbladder surgery complications, cholecystectomy.
Yes.
From my standpoint, other than pain, sort of right after surgery, what I see is patients post cholecystectomy reporting sometimes bloating and diarrhea, right? And so after surgery, we call this the post cholecystectomy syndrome. After surgery, the surgeon usually recommends a low-fat diet, right? Because of the bile dumping. So the liver is still making bile, a lot of bile, and that bile, as it dumps into the intestine, is causes a lot of diarrhea, right? It causes a lot of diarrhea. So if you limit the quantity of fat that you're having, or you add something like digestive enzymes with ox bile acids to help with this process, it does reduce that. But limiting fat, adding digestive enzymes, adding probiotics, making sure you're having a diet rich in fiber is great. There are some prescription medications we can give to counteract that effect of the excess bile. One of them being cholestyramine, cholestyramine. These are bile salt resin binders. We don't like giving it long term, really. So just working on the diet, I think, is really, really the best way to go, right? Yeah, absolutely. So if you guys don't have any more questions, we have gone way over our time. But thank you so much, Dr. Agarwal.
Thank you.
Thank you so much for joining us this evening. If you guys have any additional questions, please put them in the Facebook group. I will try and answer as many as I can. Please share this video with someone who you know has gallstone disease and maybe is concerned about testing, surgery, flushes, what to do, diet. They can always call us at our office, at the office of Dr. Vivian Asamoah right here in Katy, right? Message me on my messenger or go to our my website, Dr. Vivian Asamoah, and we would be more than happy to help. And AG Radiology, we really appreciate you spending this Thursday evening with us.
You're welcome. My pleasure, yes.
Great radiologist, wonderful facility, state-of-the-art equipment, and I mean, one of the most expert radiologists you can get to read your imaging. You guys have a wonderful evening, and we'll see you on Back to Basics Live next week, Thursday. Bye-bye.
Thank you.